Good afternoon, everybody. Good evening or good morning, depending on where you're joining us from. Welcome to the Heart Failure Policy Summit 2022. Thank you very much for joining us across Europe and beyond across the world. I'm Ed Harding. I'm the Network Director of the Heart Failure Policy Network, and it's a huge pleasure to be your chair today for session 3 of the summit, Heart Failure, Inequality on the World Stage, Connecting Advocates to the Global Policy Agenda. As you may already know, the Heart Failure Policy Network is a multi-stakeholder platform formed in 2015 to research and develop policy recommendations and raise awareness to improve care for people with heart failure, in particular in advocating for national plans across Europe. Our aim is to ensure that every person in every country can receive the same high standard of heart failure care. Our summit, as you may well know, consists of 4 sessions, and so far we have looked at how to elevate heart failure in national and international policy. And last week we discussed the role of innovation in heart failure care and diagnosis. Across these 4 sessions, we seek to answer 3 key questions that are critical to our community and to this important mission. How can we reach top-level decision makers and convince some of the case for change in heart failure? What can we learn from each other, not only in changing the design of healthcare systems, but in leading the case for change? And how can we be stronger together as a community? What do you need from us at the Heart Failure Policy Network? Before we go any further, I'd like to thank the summit sponsors, Boehringer Ingelheim, Roche Diagnostics, AstraZeneca, and CSL Vifor, without whom it wouldn't be possible to host this summit or the session today. A huge thanks as well to today's speakers who are all providing their time for free, and of course to all you attending today. So today we continue the summit with session 3, which is focusing in particular on tackling inequalities in heart failure. What do we need to know about inequalities in heart failure? How is it key to driving this agenda forward? And how can we communicate this agenda as part of our wider case for change in this important area? As the Heart Failure Policy Network, we've been aware for some time of the impacts of inequalities have upon heart failure care. For example, in our pan-European report on policy and practice in heart failure that was launched in 2020, we saw many examples of inequalities in heart failure and noted the unfortunate and worrying statistics that heart failure can arise sometimes 3.5 years earlier in some of our worst socioeconomic deprived groups, as opposed to those who are the highest socioeconomic groups. In addition, the COVID-19 pandemic has exacerbated these health inequalities, mostly in minority ethnic groups and people of lower socioeconomic position. In an effort to build back better after the position, addressing inequalities has increasingly been prioritised at the EU level by national governments. But what do we need to tell them about heart failure? We have also many new opportunities, for example, in the new ESC guidelines. So we have greater potential for keener therapeutic initiation of treatments and titration, and stronger recommendations around patient-centered care, education, self-management. These are opportunities, but also how to ensure the benefits of these new guidelines are received equally across populations with heart failure. What do we know about the therapeutic options as well, and inequalities not only in populations, but inequalities in terms of different groups within heart failure itself, such as preserved ejection fraction or reduced ejection fraction. Clearly, we have an absolutely critical topic here to discuss today, so it's a huge pleasure to show our fantastic speaker lineup. Our intention being that in exchange for your important time, we'll give you a vital run through of these critical issues, what you need to know, and how we can advocate on these issues going forward. So very briefly, a final bit of housekeeping. If you have some problems with the video, please refresh the page. If you prefer, you can turn on auto-generated subtitles by clicking on the option bottom right. And we'll be active today on social media, tweeting about our speakers and our discussion. I do hope that you'll join us using the hashtag HFPolicySummit. Finally, we'll be ending today with a roundtable discussion, and we're looking out for your questions. So if you would like to post them, we will be noting them, and I hope to bring them to our fantastic panel. So please do post your questions in the Q&A box, and we'll be answering them certainly if we can. Without any further introduction from us, thank you to everyone for being here today. It's a huge pleasure to welcome our first speaker, Professor Fausto Pinto, who is president of the World Heart Federation, who will be discussing wider patterns of CVD risk factors, social determinants, and their relationship to inequalities in heart failure. Professor Pinto, thank you for joining us, and over to you.
Thank you so much. Good morning, or good afternoon, or good evening. It's a real pleasure on behalf of the World Heart Federation to be associated with this meeting. And I'll be delighted to give you a little bit of an overview on some of the aspects that the World Health Federation has been involved with and that I believe can be useful for the discussion. I will try to share my screen now and just hold with me for 1 second. Yes. So let me give you a little bit of a flavor on what the World Health Federation is and what the World Health Federation is actually doing regarding some of the issues that may be relevant for this discussion. And considering that our main goal, our mission, is provide cardiovascular health for everyone, and through different activities, through different strategies, actually, to achieve that goal. We are an umbrella organization representing the global cardiovascular community with these three main purposes. On one hand, to connect, to lead, and inspire the cardiovascular community. Second, very importantly, to translate science into policy in order to influence agencies, governments, decision makers. And finally, to stimulate the exchange of information to achieve cardiovascular health for everyone, which altogether, that's what we are doing. We work together with our members, and we represent more than 240 members at the moment, including cardiac foundations, patient groups, scientific societies from over 100 countries. And we are also in official relations with the World Health Organization, advocating at the highest levels to bring, again, cardiovascular issues and cardiovascular health to the forefront of the global cardiovascular agenda. Now, we all, unfortunately, very familiar with these numbers. We all know, unfortunately, that cardiovascular disease still represents the #1 cause of death and morbidity around the globe. And we are not happy with this. This is the type of gold medal that nobody wants. And that's why we're trying to work so hard to find better solutions to particularly working with our members to achieve our goals. Here you can see how cardiovascular disease is changing over time. This is for stroke. We could do it for ischemic heart disease. And unfortunately, despite the fact that we've been very good at treating disease, we have not been so good at preventing disease. And this already has very much implications, for instance, for the heart failure population. We know also that if we look by disease subtype and different risk factors, we can see that this is a problem that affects not only high-income countries, middle-income countries, but also low-income countries. And actually, what we know today is that about 2/3 of mortality occur in low and middle-income settings. And also we know that about close to 80% of cardiovascular mortality actually could be, or cardiovascular disease could actually be preventable. And that's actually one of the things that really affects everybody, and in order to try to find how we can do better prevention and how we can do better management of the situations when they happen, that we try to work together. We also know that there is inequality, and that's one of the issues we're discussing here. And you can see here the inequality in improvement. You can see on top low income settings, on the bottom on the high income settings, and the global. And unfortunately, we can see that although there's been some work done and some results, but we still have a huge difference between different settings. And sometimes even within the same country, we find this type of inequalities. And this is actually one of our main goals, is tackle inequality in the management of cardiovascular disease and also in the promotion of cardiovascular health. So the problem that we face today is that although we all know the causes of cardiovascular disease, and we do have very important and very cost-effective treatments, there is a huge gap between evidence and practice. And we have not been good at implementing what we already know. I'm not even talking about innovation or new treatment strategies, but if we could apply only what we know, data, for instance, from Eurostat has shown that we could avoid 1 out of 3 deaths in the OECD environment. And the majority of these, unfortunately, are also in the cardiovascular field. The United Nations in 2015, they developed a group of Sustainable Development Goals, and one of them is 3.4. And the goal here was to reduce by 1/3 premature mortality due to NCDs, and particularly cardiovascular disease. And this is very much what we've been trying to follow. Unfortunately, at the moment, only 14 countries are actually on track to achieve this goal, which means that the majority of countries most likely will not achieve this goal. And that's why also we're trying to work in different levels to try to push forward and to accelerate measures that can help us at least to be close to this goal of reducing by 1/3 premature mortality due to cardiovascular disease. And at WHF, we are doing that in different ways. One of them are the roadmaps. The roadmaps are key reference documents which outline a vision of an ideal pathway of care for cardiovascular disease patients, roadblocks along this pathway, and evidence-informed solutions and examples from practice. We focused on assisting the leaders in cardiovascular health to assess needs and gaps in their communities, to organize a framework to assess national priority areas along an ideal pathway of patient care, and then identify the different roadblocks along this pathway and look towards examples of evidence-based solutions that could be relevant in different settings. We organized these roadmaps for the last few years on different topics. Usually we do about 2 per year. This year, we already launched 2, one on digital health and one on cholesterol. We did launch in 2019 one on heart failure that contains quite a lot of information, and particularly of potential solutions that can be applied in different settings, trying to overcome the roadblocks related with the implementation of guidelines. So the roadmap basically is an integrated approach to patient care involving the different stakeholders from patients, carers, patient organizations, civil society, healthcare professionals, and the leaders in cardiovascular health, as well, particularly decision and policymakers. And at the national context, we organize national dialogues, looking at roadmap recommendations, doing situation analysis, organizing plans of action, and organizing also what we call scorecard data, which basically provides, it's a key to identify policy gaps and also to set priorities at the local region. As I've mentioned, we've been producing these different roadmaps. These are the 2 last ones. One that was launched at the ESC in Barcelona, the one on digital health, and the one on cholesterol that was launched just a couple of weeks ago at the World Congress of Cardiology in Rio de Janeiro. And this is just one example of the success of these roadmaps. This is in Kenya. It's about hypertension, which is probably the #1 risk factor that is one of the main responsibles actually for the involvement of and development of heart failure. And this one, we organized different roundtables, and together with our colleagues in Kenya, this resulted in a national call to action, empowering people living with NCDs, establishing national registries, creating an enabling environment for task sharing, taxing and healthy communities. And all of this resulted in a better dissemination and implementation of new guidelines to manage hypertension, which included strengthening of surveillance and task shifting of hypertension detection and management with concrete results in the field, and we're reproducing this in other parts of the world. Now, another important development at the World Heart Federation has to do with a better use of data. Of course, we need data, and we need reliable, accurate data, so we can have access to this reliable data should actually be the first step to develop and implement effective health policies. And data helps us to understand better the different diseases and conditions so we can make the right decisions. And also quantifying the burden of disease help us to identify conditions and risk factors to target and provides important input into health policy discussions. And that's why we created the first global data hub called the World Heart Observatory. And our goals are first to inform evidence-based decision-making for health at the population level. Secondly, to build data capacity among national and regional organizations. And thirdly, to create a forum for research and debate for cardiovascular health. This is our observatory. It's online, was launched this year in February in Geneva. We are working with different partners right now. Most of the data is coming from the GBD group. We're also working with HME, but we are working with many other organizations in order to provide this platform and this hub for data. And we are looking now into different elements that can help us to expand and to make this even more useful for our members and for our population. We also use different methods to reach out to our targets, and one of them is by turning data into stories. So provide visualization by creating stories related with specific individuals. These are just two examples, one on rheumatic heart disease and the other one on hypertension, reaching out better our population. The World Heart Vision 2030 is a document that was produced by WHF and that was just launched also at the World Congress of Cardiology. And it's looking a little bit into the future, into the next decade, on what should be our priorities. And we faced here different collective goals. And that's why we looked at this document as a comprehensive document and hopefully guiding some advocacy and some communication efforts, emphasizing its use on what we know and building basically on knowledge and innovation. We focus here on 4 different paths. One is paving the way for cardiovascular health equity, and that's very much one of our main concerns. Second, to foster timely implementation of knowledge. As I mentioned at the beginning, we know what to do, we're just not doing it properly and implementing it properly. So it's very important that there is timely implementation of the knowledge that is created, and then leveraging innovation and technologies for cardiovascular health. And finally, to place cardiovascular health at the heart of health and climate policies. And each path has a set of key messages and calls to action, which I will not get into detail, just that gives you a little bit of an overview of these different pathways. The first one on paving the way for cardiovascular health equity. And of course here, increasing the awareness on the different cardiovascular health issues around the globe, and particularly the ones that may affect more certain populations, development of policies and programs that can expand cardiovascular health education, and also providing support for research and clinical trials that very importantly include data from underserved communities, which is one of the issues that we are facing also, is many times the clinical trials do not reflect the populations that we are dealing with. The second, on fostering timely implementation of knowledge. It's very important to close the healthcare gaps by 2030, as we have seen, between preventive and curative measures. Research findings, rather than basically sit on the shelf, it's important that there will be this timely implementation of knowledge created. And also primary care health systems, they must engage and empower patients while facilitating task sharing and task shifting, which is probably one of the areas that we must work more heartily to ensure this timely implementation of knowledge, particularly in some settings. Leveraging innovation and technology for cardiovascular health. That means new technologies that must foster patient engagement and empowerment through different interventions, for instance, via digital means, and many other aspects that can basically improve this access to innovation and technology. And finally, very importantly, and I think this meeting today is a little bit part of this, placing cardiovascular health at the heart of cardiovascular or health policies. And here is where we have to work very closely with the decision makers, basically providing the data, providing the evidence that then can be used to make and to take the right decisions to be implemented at the community level. So this World Heart Vision actually is focusing basically on all the stakeholders, from governments to health professionals, civil society, the private sector, and so on, so we can reach out as much as possible the different players that can make a difference on implementing proper strategies. With this, I will finish. I will just wanted to say that, of course, we are working in many other fields, but this gives you a little bit of a perspective of some of the areas that I would like to share here with you, and that then we can maybe have a little bit of time at the end to have a little bit more discussion. So thank you very much for your attention, and I'll be more than happy to, at the end, answer any questions or provide any sort of additional comments. Thank you so much.
Thank you, Professor Pinto, for that fascinating oversight. And I think of the depth of resource that's available there for in terms of the wider debate on cardiovascular disease. We've talked at the Heart Failure Policy Network many times on the importance of understanding what's specific to heart failure, but as well as the wider direction of travel, the political momentum, but also the policy tools that are there. So I hope that everyone today has got a comprehensive sense of what is available, as well as an understanding of the importance of health equity within them, and your insight as well on equity, as it were, between countries also, and global regions being very important. As Professor Pinto said, we also have to connect numbers and data and tools to a sense of meaning and to communicate meaning as well. And I'm sure everyone in the at the summit today will agree that in this aspect, we have to answer the question of what inequalities mean to those living with CVD, and in particular here today, those living with experience of heart failure. So on that note, it's a huge pleasure to turn to Aiste Starate, who is chair of the Global Heart Hub Patient Council and president of the Lithuanian Heart Failure Patient Association. So Aiste, thank you so much for being with us today.
Thank you very much. Thank you, Ed, and welcome everyone.
So a question for you, Aiste. In terms of your personal experience, could you tell us about your experience of being diagnosed with heart failure?
Absolutely. So my story has started in 2016, actually. I wasn't even 30 years old back then. And I was living abroad. I was living in the Middle East at that time. And being a young female leading an active life, I started feeling actually a cough. That was my first symptom, which back then, again, I didn't know that was related to my heart. So obviously being, responsible, if I have a cold, I would, try to heal the cough or any sore throat with ginger lemon tea. And that's what I did. I was trying to heal myself. But after 1 week, I saw that there is no improvement of that. So obviously, again, being responsible patient, what I did, I actually took myself to see a general practitioner and actually asked about what could cause potentially my coughing, a dry cough, which is very uncommon because I was not a smoker. And after a few tests, I was only issued some medication to treat the symptom and was sent back home, basically. So another week went by and my symptoms actually started to worsen. So then I started feeling weak and dizzy. I as well realized that I started gaining the weight. So by the start of my diagnosis, I gained around 10 kilograms. So that's quite a lot. And obviously it explains all the coughing and all the shortness of breath. Again, after 1 week, I was going back to the GP with an extra symptoms of that. And again, I received the medication for the symptoms and nothing was looked at as what could potentially cause all of those symptoms. And I could explain you more and more. So basically, fast forward 1 month and a little bit, 1 month and a few weeks has passed, to the point where I was really feeling all my symptoms to the maximum. I was going back again to the doctors and again, not receiving the right treatment. The only one thing that, I'm grateful for at that time, I was wearing the Apple Watch and I could definitely track my heart rate, and my heart rate was jumping from really high to really low. And that I would bring that to my GP's attention, saying, can you please look at the reports, because, I have them by day, by the hours, even by the physical activity, what I was doing. So it's quite easy to kind of follow that. So I was like trying to asking the GP to actually evaluate the heart rate and, maybe that could lead somewhere. The only recommendation what I was given at that time was that it looks pretty normal because I'm a young person. So I'm, leading an active life. To the point that, my next question was like, is there a line where I should be worried? So when do I need to seek help? When I know that something is not right? And let me tell you, like now with all the experience, I'm already a patient advocate, which is knowledgeable and educated. But back then I did not have knowledge about the cardiovascular disease. So I didn't know what to look at. And back then, the general practitioner has told me that, I have to really watch out if the heart rate goes really up high and it doesn't go low. So that was kind of a key indicator for me. When do I need to seek help? And I know that something is really going wrong. So, and it actually happened to the point that I mentioned previously, after more than 1 month, being with all the symptoms, not being able to lay down. I was sleeping back then while I was sitting down, taking my cold medication, different type of medications I was giving through that whole month. And to the point that I woke up from the night sleep and my heart rate was around 160 beats per minute. And I'm not lying, like I was really calm within myself. I knew that my heart is racing extremely. I had a feeling that, my heart will probably jump out of my chest. So I called the emergency straight away. I explained them the situation, and they told me to kind of calm down, even though I was calm, and basically seek help and come into the emergency if it doesn't go away within few hours. After 1 hour, I was already in the emergency, and I had all the team like jumping around me saying, you've been coming in for the visits for the past month and a little bit. It's like, why nobody has checked that, something is related to your heart. Straight away, the next point, I was actually directed to the cardiologist specialist who actually spent time with me, explain all the situation, explain me the diagnosis, explain me how I need to live a life, how I need to restructure it, and explained all the treatment as well, what the medication, there was a full bunch of medication that I was taking, which I really didn't know for what and how, and using them, it really just made my body, how can I say, just really extremely, it went to the extreme to one side or another side with the side effects. And it was very difficult to stay sane during that time until the medication started really working on me. So that's like a little bit of beginning of my story in the short minutes.
Thank you, Isa, for sharing what was obviously a horrendous experience with us. I'm sure it's a difficult story to tell. Could I ask you, do you think that your age and gender had an impact on your experience?
Back then, I wouldn't really haven't focused on that. Like, I've been diagnosed, I was on point on my treatment, I was following it, I was doing what needs to be done, I was getting educated. But now as more information, the more time has passed, and now more I'm getting into the patient advocacy and inequalities and everything. Now it makes sense to me that it might actually had an impact in terms of my age and on my gender, and how the way I presenting, and being the female and having a slightly different symptoms as like a standard pack of the symptoms for heart failure being invisible disease as well. The first thing, I went to my cardiologist office, he just looked me from the bottom back to my eyes and then again back to the feet. I had no swollen ankles because the whole liquid was around my whole body, and mainly the belly part. So it's completely different. And being a young patient and being a young person leading an active lifestyle, I would think that I probably haven't rested well, or I had much stress probably at that time. So I would think at that time that symptoms kind of were coming from that sense, and wouldn't had that knowledge to go and and even seek and empower myself as a patient, going, can you please check my heart? And I think something is wrong, because the symptoms, the beginning of it was so misleading that I could potentially didn't know myself. And I think it, in a sense, back then for me, it looked like it doesn't matter, if you seek help or not, patients are getting like misdiagnosed anyway, because, I was that responsible patient knocking on the doctor's office, and I still didn't get the diagnosis, which again, when I heard the diagnosis, I was already end-stage heart failure.
Thank you, Esther. And how would your experience relate to others in your role as chair of the Heart Failure Patient Council of Global Heart Hub? You've talked to many people with lived experience. Do you see commonalities and patterns of particular people groups, people certain backgrounds? What's your view on your experience and how they relate to others?
So I definitely speak a lot of with a lot of patients with the similar stories. I could definitely say that in a global setting, for example, I met a lot of similar with a similar age and similar experience patients, which is very interesting as well. So probably interesting enough that they all been diagnosed either after like some sort of episode or in a hospital setting. Most of the young patients, they haven't heard about the cardiovascular disease before, which again leads to that of lack of awareness in societies, and especially in the younger generation. With other groups of the patients, definitely there are some points highlighted in terms of inequalities and age and sex and ethnicity, even, you know, how they perceive the symptoms of, you know, to the point that having the access to the doctor's office, or even, you know, having actually possibility to hear the diagnosis that, you know, you have a heart failure and you have to now rethink your life and you have to take the steps according to that. So there's definitely similarities in the stories, and there are some which we as a community really learn from, and I think that's why we're here to do that.
Thank you so much, Isti. And in the panel, you're looking forward to the views of the Patient Council in terms of what they want to see and some of the origins of it. Thank you so much for joining us. I was just reflecting on the work that we've done in looking at the research, how difficult it's been sometimes to find evidence of inequalities, and I guess the lack of research there, making it so important that we hear your reflections and also the communication of others that you've gathered in your conversation with others. So thank you, Isis, so much for joining us, and I look forward to speaking to you in the panel.
Thank you.
On the note of evidence and research, moving to our next speaker, I'm delighted to welcome Professor Amitava Banerjee from the University College London, who's joining us today to discuss the connection between ethnicity and heart failure, drawing on his experience as a practicing doctor and a researcher. Professor Banerjee, it sounds like a very important time, very timely moment to hear from you. So thanks again for joining us, and over to you.
Thank you very much, Ed, for the introduction and the invitation. I'm just going to share my slides. So my name's Amitava Banerjee. I'm a cardiologist and professor of clinical data science, and I specialize in heart failure. And I've been asked to talk about ethnicity with a research and a data lens. I am based at University College London and clinically at Barts Health, and I'm the trustee of the South Asian Health Foundation. So I'm very interested in ethnic disparities in health, and I'm also involved in various other roles, both in the British Cardiac Society and the World Heart Federation, which make me very, very much aware and even more interested and passionate about getting rid of, if not trying to tackle, the inequalities that we see. So today I'm going to mention briefly about the inequalities in terms of definitions, healthy lifestyles, underlying conditions in relation to heart failure, COVID-19, which is obviously very much in our minds over the last 2.5 years, and then recommendations. So in terms of how to think about health inequalities, equality is the picture on the left here, where everybody gets the same view and the same solution, but it might not match the need. So you can see the person on the right is not served by this solution. Equity is where we make sure that everybody has that equality of opportunity and equality of solution. And the ideal is on the right here, where we remove those barriers. Now, even though we are talking about heart failure I think of as the kind of unifying diagnosis across cardiac disease. All heart diseases can result in heart failure, and all risk factors can contribute to heart failure. I've listed some common lifestyle risk factors: the diet, alcohol, smoking, exercise, mental health, and importantly, access to healthcare. And in terms of ethnicity, we started being aware of this in the UK in the 80s, really, when people started noticing higher rates of diabetes, higher rates of cardiovascular disease. Actually, it was realized earlier than that, but really it was the 80s and 90s when the research evidence piled up. And this quote famously from Kamlesh Kunti at the University of Leicester and Nilesh Samani, the head of the British Heart Foundation, is very apt, I think. If the epidemic of coronary heart disease in South Asians is a disease of migration, people moving from South Asia to the UK, and has occurred within a generation, there's no reason why it should not be reversible on a similar timescale. So they were saying that this is something that we can do something about. Now, one of the problems with inequalities is that we need political will. And even in our country, that there's misinformation and sometimes misinformed views from our policymakers. This here is an example of, unfortunately, of a Conservative MP who feels that food poverty is due to lack of cooking skills rather than structural inequalities and poverty. And that leads me to 2 points, really. First of all, one of the problems that we see in data is that we've considered research or science in this slide evidence in terms of guidelines and what to do with people with heart failure or how to prevent heart failure, and care, what we actually do in the clinic or in the hospital. Those three circles or silos are separate, and we need to join them together so that the science is being informed or informing the care and vice versa, and that the guidelines are updated quickly. So one of the problems is that there's a gap there, but also on that, we need to think of the context. We need to be admitting where our knowledge and expertise lies and where there are limitations, which this individual on the left is not listening and learning from, whether it's patients or health service providers, adapting and delivering. I think trust is really important, whether in terms of I'm talking about ethnic inequalities, but I think any inequality, it needs to involve trust with the end users. And the broader social determinants of health are as important in heart failure as any cardiovascular disease. This is a famous diagram from Michael Marmot, where we see that the kind of more upstream you go, work, education, poverty, these things end up being very important. It's not just about coronary arteries and heart function. Going back to heart failure, what are the underlying causes and where might the inequalities be? So we looked at this in a study a couple of years back, and across European guidelines, there are 92 risk factors for heart failure. So we looked in electronic health records at 200,000 people and looked at what those risk factors looked like, how common they were, and how they affected people's prognosis, how their survival was based on risk factors. So, and we also looked at the evidence in terms of trials for whether we had evidence that preventing those risk factors led to less heart failure and better outcomes. And the first thing we found is that there were only 10 risk factors with evidence of the association that was high quality, and there were only 7 where randomized control trials, which are the highest type of evidence for an intervention working, showed that heart failure could be reduced by preventing these risk factors. And then we looked across these 92 risk factors, and we showed that there's a huge variation, not just in how common they are, and you don't need to worry about the detail, but just to say that at the bottom here, heart failure in pregnancy is related or associated with a 5-year mortality of about 5%, whereas if it's pheochromocytoma, which is an adrenal tumor, relatively rare, but still an underlying risk factor for heart disease, it's associated with nearly an 80% mortality. So what the risk factor is matters. And there's also ethnic variations across these risk factors. But the important thing, even though there's 92 risk factors, is that actually 1 in 6 individuals have no recorded risk factors, or put the other way around, 5 out of 6 individuals have risk factors where we can do something about it. So there's an unmet need for prevention, whether it's blood pressure, whether it's trying to do better at treating or preventing heart attacks. So this is where this idea of primordial prevention, which is preventing the causes of the causes, and primary prevention, which is about treating risk factors, and secondary prevention and tertiary prevention is important, because at each of these, ethnic minorities, whether it's in the UK or whether it's in the US, or in other countries where there's ethnic diversity, they do worse, whether it's at primordial prevention or tertiary prevention. Now on to COVID. So coronavirus has really caused an enormous impact across all of our health systems, and it's done it in a number of ways. We've focused on the direct effects, which is the effect on COVID mortality, the effect on being admitted to hospital or ITU, intensive care units, but it could be indirectly as well in terms of the effect on non-COVID healthcare, the effect on non-COVID deaths because of changes in patient behavior or because of strain on the health system. But also there have been effects in terms of long-term effects. Now that could be cardiac effects specifically due to coronavirus, or it could be cardiac effects within the so-called syndrome of long COVID. And heart failure here, you can think of as a risk factor, as a disease, as an outcome as well. And I've, on the left here, I've mentioned a paper that we published in my research group in March 2020, at the height of the first wave in the UK using electronic health record data. We can do that in the UK because we have universal healthcare access and we have relatively good data. In most parts of the world where there's cardiovascular disease burden and heart failure burden, as my colleague and friend Professor Pinto was saying, there isn't that same data. We're trying to gather that now, but we want to be able to link that kind of data to the risk of COVID and future pandemics. And on the right, I've listed here in the South Asian Health Foundation how we had a targeted risk factor based approach in the South Asian community and in ethnic minority communities, both visual and in terms of reports. Because ethnicity is associated with increased underlying risk, increased risk of infection, increased risk of hospitalization and mortality, and then conversely, with reduced rates of vaccination and reduced use of the digital health solutions that we saw more and more during the pandemic and even currently. So once we know the problem, then we can set about solving it, and we need data for that. So my recommendations are that we need to be multi-sectoral, and whether that's across risk factors or across specialties, and we need to have the policymakers with us, not just lifestyle recommendations. And we have to take on some of the more sticky structural and behavioral problems, which we often don't take on because they are related to heart failure, this pandemic and beyond. And we do need to recognize that there's community specific solutions. Thank you very much.
Thank you very much, Professor Banerjee, for that incredibly insightful the view and research and summary of the issues at stake. And as you said, the need for that depth of understanding how important data is for the richness and complexity of the prevention pathway from primordial all the way to tertiary, which I look forward to taking forward in the next discussion. So thank you a huge amount for joining us. Moving on to our next speaker, I'm delighted to welcome Dr. Natalie Conrad from the University of Leuven, who will share with us some insights on her widely cited research on socioeconomic inequalities in heart failure. Dr. Conrad, thank you so much for joining us, and over to you.
Thank you, Ed, and thank you to the Heart Failure Policy Network for inviting me to speak today. So I was asked to speak about socioeconomic inequalities in heart failure as subject matter, which I've done quite a bit of research. So when we talk about socioeconomic inequalities, people usually think about access to treatments. But inequalities actually happen at any time along the patient's journey of care. And so in my research, I've tried to look at three key aspects of inequalities. First, the disease onset, that is who develops the disease and at what age they do so. Then the care they receive, and that is where and when they're diagnosed, the diagnostic tests, and of course the treatments they receive. And finally, the health outcomes, to see if there are groups that are more likely to be readmitted to hospitals or to die following the heart failure diagnosis. So for this study, I've used data from electronic health records from the UK. This data is really unique because it provides information on the whole journey of care of heart failure patients, from diagnosis to treatments, hospitalizations, and death. We had access to about 4 million individual records over 12 years. And among these, we were able to identify about 100,000 patients with heart failure, so that the data was sufficiently large to look into specific subgroups and trends over time. Another aspect that makes UK data really special is that it provides information on individuals' socioeconomic status as the index of multiple deprivation, which is a composite measure of social and economic characteristics, including income, education, employment, or living environment. So the first thing we did is to look at heart failure incidence, that is, the number of new cases of heart failure per 100,000 persons each year, across socioeconomic groups and over time. And this is the figure you can see here. What you see here, sadly, really is a perfect gradient from the most deprived group in black at the top with the highest incidence of heart failure to the most affluent group in the light blue line at the bottom with the lowest incidence of heart failure. And the variation is considerable, really. People from the most deprived socioeconomic group were 61% more likely to develop heart failure than those in the most affluent group. And disparities did not change over time. But inequalities were also apparent in the age at which heart failure developed, and patients from the most deprived socioeconomic group were significantly younger at diagnosis than those from the most affluent group. And importantly, this gap widened over time. So what you see on this figure is the average age at heart failure diagnosis. And you can see that the age at first presentation actually increased in the most affluent group, meaning we have managed to delay the onset of this patient population, but it has decreased slightly in the most deprived group. Then we had a look at how the delivery of care changed by subgroups of patients. Here we considered 5 indicators of care, which you can see on the slide here. We looked at initial diagnosis in an outpatient setting, that is, as opposed to during a hospital admission. Then among those diagnosed in a hospital, whether they were follow-up by their general practitioner within a year, diagnostic investigations, treatment initiation for those with reduced ejection fraction, guideline indicated medication initiation, and total dose over a year. And so what we found is that actually there were little socioeconomic disparities in the rates of diagnostic investigations and treatments, but where we really saw socioeconomic disparities were in the setting in which heart failure was diagnosed, and those from the most deprived group were much more likely to be diagnosed during a hospital admission as opposed to an outpatient setting, which, in the end meant that they were overall more likely to be followed up by their GP over time. And so this does suggest that perhaps early signs and symptoms were not appropriately recognized in these patients in non-acute settings, or of course it could reflect patient preferences to seek care in hospitals or difficulties in accessing outpatient consultations. Now, when I was listening to Aistre's presentation, and thank you very much for this, I thought it was really fascinating to see the perspective of a patient, and particularly young female patients. When I looked at this data originally, I also found that those the youngest one, and particularly women, were those with the lowest rates of diagnostic investigations around the time of their heart failure diagnosis, suggesting that perhaps this is not just one case, but it is something that is difficult for healthcare systems to work with, because heart failure is indeed relatively rare in young women, but it does happen. So, and those to whom it happens do find it difficult to get the right diagnosis. So we did see this very clearly in this data here from the UK. Okay, so then we had a look at mortality after diagnosis and found that individuals from most deprived groups were 20% more likely to die within 1 year of their heart failure diagnosis than those from the most affluent group, and that after accounting for differences in age, sex, and comorbidities. This appeared to be partly driven here again by the place in which there were first diagnoses, because as you can see at the bottom of this figure here, those diagnosed during a hospital admission were significantly more likely to die within the year after the heart failure diagnosis as the others. Okay, so to summarize, patients from the most deprived group were about 60% more likely to be diagnosed with heart failure, and they developed the disease at a younger age than those from the most affluent group. They were more likely to be diagnosed during a hospital admission as opposed to their GP or another outpatient setting, and about 20% more likely to die within 12 months of their heart failure diagnosis. I'd like to mention here that healthcare in the UK is universal and free at the point of care. Of course, as we can see here, free access does not guarantee equal access, but it is likely that in other healthcare systems where healthcare is not free, disparities might be even more pronounced than that. Okay, so what does it mean in terms of public policy? Well, to me, really, the most important finding here is that if we can prevent or delay heart failure in the most affluent subgroups of the population, then it means we can do it. We can do it for everyone, and we should do it. So it means we need more targeted prevention measures that really specifically address these socioeconomic disparities in risk factors and prevention measures that affect patients who are likely to develop heart failure. And one of the key findings for me was to also that when we talk about disparities, we do need to look at those that not only those that are already followed up and part of the healthcare system, but look first at those who are not diagnosed or diagnosed late, because perhaps those are the most in need. Thank you.
Thank you so much, Dr. Conrad, for that, I think, quite stunning data. I'm sure everyone who's at the summit here today will be, if they haven't seen it before, be really quite affected by the comprehensiveness of that finding, not only on a single lens of population or an issue, but that comprehensive view across the piece, rooted as it is in such depth of data. So a huge thanks. I think it's an enormous, and clearly it's an enormous challenge, isn't it? And it's I see in your presentation and the speakers before a rallying call that requires undoubtedly a strategic and system-wide approach, as you were just pointing out. I think there could be no better moment to now move to our next speaker, Dr. Antonia Sambola, who has a fantastic privilege. We're delighted that she's with us here today, as she is able to speak from experience as to how the Spanish Society of Cardiology, their Women in Cardiology working group, influence the Spanish national strategy on CVD, which if you're not aware of or haven't heard of, we discussed in our first session, and is one of the most exciting examples of CVD policy at the moment in terms of new CVD policies. So what greater moment, I think, to hear from Dr. Sambola as to her experience about working within that strategy, and to speak to us as a consultant at University Hospital Vall d'Hebron in Barcelona, and a member, of course, of the Spanish Society of Cardiology. So, Dr. Sambola, thank you for joining us, and over to you.
Thank you. Thank you. Good morning, everyone. Thank you for your kind invitation to participate in this interesting session. The working, next, please. Here. The working group at the Spanish Society of Cardiology was created because we had two important concerns. First, there is limited knowledge about the different cardiovascular diseases in women regarding the pathophysiology, epidemiology, access to different treatments, and prognosis. And second, there are relatively very few women holding top positions in cardiology. And women in cardiologists don't advance at the same rate as men. And the evidence suggests that the gender gap is present in the medical world. And here you can see the most relevant appointments reached by women in different institutions, and there are few appointments. And this slide, this figure was published recently in 2021. Next slide, please. The first thing that we did from our working group was to know what are the data. And cardiovascular disease is the first cause of death in women. And as you can see, the heart failure is the third cause causing this death in women. And you can see in our community, the prevalence of cardiovascular disease is higher in women than in men, as well as the mortality, 30% compared with 20.6% in men per year. And heart failure, concerning the heart failure, affects a 9.8% of total population. And there are more or less 278 new cases of heart failure for each 2,079 people. And more than 60% are older than 75 years old. And then here you can see that the mortality due to heart failure is higher in women, that I mentioned, around 18%. Please, next slide, please. After that, after knowing the data, we set in some key priorities in heart failure. And we set key priorities in order to improve the inequities in heart failure in our community. First, the three key priorities were setting as improve the detection of prevention of heart failure in men and women. Second, organize heart failure units with equal access for men and women. And third, organize a network to attend patients with cardiogenic shock with equal access to men and women. And how we can achieve these key priorities. First, to make health promotion, disease prevention, and early detection, and improving the empowerment and citizen participation, and to improving the knowledge management, research, and innovation in heart failure. And one point very important, to improve the equity and gender in cardiovascular health. The other 2 points very important also are the comprehensive approach to the person with acute heart failure as well with chronic heart failure. Next slide, please. And here you can see one example how we can find inequities between gender or sex in cardiovascular disease, and specifically in heart failure, and more in cardiogenic shock, that is the leading cause of death in heart failure. We found a higher incidence of cardiogenic shock in the setting of ST elevation myocardial infarction in women. In a huge nationwide registry, including more than 200,000 people, and with ST elevation myocardial infarction, and among them there were 20,000 people with cardiogenic shock, and 39% were women. As you can see that we analyzed 13 years, and we found that women show a persistent higher incidence of cardiogenic shock in this setting. And in the other side, the mortality was higher in women, 79%, compared with 65% in men. And this was independently that if women were admitted in the intensive cardiac care unit, and with specific resources to carrying the cardiogenic shock, and then to care the cardiogenic shock. And then you can see that if the women were submitted to PCI, the mortality was higher in women than in men. And then next slide, please. Next slide, please. And this is the role of women in cardiology sections in medical organizations, for career development to professional enrichment. And you can see this is the other point that our working group is setting with a work planning. And this is the things that we believe that can improve the position of women in the cardiology. And thank you so much for your attention.
Thank you so much, Dr. Samboda, for giving us that further insights into cardiovascular disease and heart failure and its and particularly impact on women there, but also what we can do to elevate women in cardiology and cardiology careers is going to be, I think, a vital contribution to addressing these issues. Unfortunately, I should also mention that one of our expert speakers today is unable to join us, Professor Martha Gulati, who's unable to come due to unforeseen circumstances, but we do hope to secure a presentation from her in due course. Moving then on to our next speaker, Ms. Anne Ray. Thank you so much for joining us, our last speaker of the day before we move to the roundtable. Ms. Ray is part of the Bristol Inner City Primary Care Network, and we're thrilled to have her with us today to share a case study on tackling inequalities in a UK city reaching disadvantaged groups through innovations in data linkage and social prescribing. Thank you, Anne, over to you.
Thank you for having me today. I'm Anne Ray. I'm an advanced nurse practitioner from Bristol in the UK, and I work in general practice, and I'm a health inequalities lead for the Bristol Inner City Primary Care Network, which is a group of general practices that work together at local level. And I'm here to give you a practical example of how we use population health management to identify and improve the health of a population at higher risk of developing heart failure. So to quote NHS England, population health is population health is an approach that aims to improve the physical and mental health outcomes and promote well-being and reduce inequalities across an entire population. And this is because improving health needs to include focusing on the social determinants of health, as well as access to healthcare, for example, work, housing, education, and the whole environment that person lives in. In our region, we have, so that leads us to what is population health management, and we have our own definition, which means accessing data beyond just health and care records to include this data about the social determinants of health, and then working in cross-organisational teams to understand this data and work collaboratively to design services that will improve the health of our communities. So I work in an area with many health inequalities. We have a PCN population size of over 84,000. We have high deprivation and a young population, and 42% of our population are for ethnic minority groups. But people who live in our PCN are more likely to die earlier and have fewer years of good health than those in the least deprived of the region. So we use linked data to help us to understand our current and predicted population health and care needs, including the social determinants of health. We were given data from multiple sources, which showed us social risk factors like were they a carer, are they a carer, deprivation deciles that uses crime, education, employment, health, disability, housing, income, and living environment, ethnicity, age, physical health, mental health, and activity and economic measures. And we formed a partnership with a wide range of organisations, which is a key part of population health management, to work together collaboratively. So when we looked at our linked data, we looked at it in the context of population segmentation and risk stratification. So population segmentation is separating populations into subgroups so that we can better assess each group's wants, needs, and health priorities, clinical, geographical, ethnicity, age, and risk stratification that's used to predict adverse events that are undesirable, costly, and potentially preventable. And the data showed significant multimorbidity in our population. So, for example, 80% of our population with heart failure also has hypertension, 42 also diabetic, and 21 also had depression. And we also saw the high impact of heart failure that had on emergency admission for the patient and the NHS. So we decided to go upstream and identified a cohort of 102 patients who are most deprived and higher risk of developing heart failure, to improve their access to care and address the social determinants of health that would put them at high risk. So in partnership, we designed 3 interventions with short, medium and long-term outcomes. This included a desktop review, a social prescribing referral to navigate to voluntary community sector options to address some of the social determinants, and a healthy heart group consultation, which had a dietitian, physio, social prescriber, link worker and nurse to offer peer support and health promotion. So we had a number of key challenges. This case study was run over the pandemic, so it reduced capacity and limited our interventions. We had no clear revenue streams for creating and implementing interventions, so it was all at our PCN level and resources from the general practices. And we had cross organisational partnerships, took time to develop. And we had some really fantastic successes. So all our eligible patients were contacted and 40% agreed to a social prescribing referral. They all had their desktop reviews. We piloted the Healthy Heart Group consultation with positive feedback from participants. And we're now using this approach to identify and address inequalities and their causes into our sort of routine PCN work. And finally, this emerging model of proactive care with collaborative working at neighbourhood level is also becoming part of our routine practice. So we've got NHS produced a video about our case study, and we've also have a couple of reports on these websites if anyone wants to read more. You're welcome to contact me for more information or find me on Twitter. It's been a very quick run through of this case study, but thank you for listening.
Thank you so much, Anne, for running us past that fascinating example of, as you say, determination to identify those who might benefit the most and to develop a flexible approach to the services at your disposal. I'm sure it had many challenges, but I'm certain that would be an inspiring example to many colleagues. So on that point, thank you all to our fantastic speakers for joining us today. We'll move now to the panel discussion section. So I'd like to welcome our many speakers back to join me. And to start, Aiste, with you. You told us at the beginning about some of your personal experiences and reflected as well on those of others. Now, reflecting your role as the chair of the HF Patient Council at the Global Heart Hub, what do you and your colleagues see as some of the causes of inequalities in access to diagnosis and care?
Thank you, Ed. Yes, well, obviously the conversations are rolling, and we definitely see some issues in patient stories, like day-to-day patient stories, where we see some inequalities in different aspects. And I can definitely mention a few of them with very, very simple examples. And I would like to start with a social, for example. I know this inequality is very, very broad, and I'm not going to go in depth with it, but I just want to mention that, you know, the gender, age, race, ethnicity, like all the issues are there. And from the patient stories, we really see that there's a clear need of equality in those areas across all the diagnosis, treatments and care in general in heart failure globally. I would like to mention as well the income, you know, giving this very simple example of, for example, treatments or access to care. For example, access to private care versus to public care. In private sector, patients can go and see the doctor in 5 working days. But in public, for example, if the patients cannot really afford the private, they can actually are made to wait up to even like 3 to 6 months to see the doctor. So there's a big difference and a big gap there. I would definitely highlight the education, which is another very important thing in heart failure. And very example to that is simple, just materials about heart failure in English versus to other languages. So we see that there is a great content information in English language, but then the materials are not always translated into the other languages, which is again this difficulty for those who don't speak English. On the top of it, the level of literacy in general is an issue, and as well like using tools such like internet or like different apps. We know that the apps are very popular now in heart failure, tracking your symptoms, tracking your medication, tracking your day-to-day activities. And we know that there is a big difference between the older generation learning versus younger generation. I think one of the top priorities and in general, the issues that we see is access to care, and it probably will be there for some time until we see the big change. That includes the timely diagnosis, treatments, availability, rehab, post-care. And I would like to give one example about the patients who live, for example, in rural areas and have no access to care. So some of the patients, I do really hear that quite a lot, especially in big countries such Canada, United States, that, patients really need to travel up to 6 to 8 hours to reach the doctor's office versus someone who lives in the central part of the city and has an easy access to the doctor's appointments and as well the emergency services. Last but not least, I really would like to put a spotlight on the mental health. I think it's highly overlooked in heart failure, and there's a very minimum or nearly no access to mental health professionals in CVD. But we know that it's around 60% of patients have a depression after heart failure diagnosis. So I think that's a crucial part as well. So I think that would be the main points that I wanted to highlight. If you have anything to add, I would love to hear that.
Thank you, Isti. Can I turn also now to Professor Banerjee? You spoke to us earlier, and as you mentioned, you're a practicing clinician as well as somebody who works in research. Just reflecting on the conversations today, I wonder what your message might be to your healthcare professional colleagues. How can this affect everyday practice, and where do you see some of the greatest potential for action in terms of changing the way that we organise prevention, care and support?
I think that we need to be multisectoral, as I said, and no one person, whether it's the health professional or the researcher, can cover all the bases. So we need to be humble and admit our limitations, and we need to push for data where there is scanty data or no data, because that allows us to do everything from advocacy to formulating solutions and doing quality improvement. So I would argue that the best research is seated in clinical practice from routine data, and that can show inequalities in data. It can show inequalities in certain groups not getting diagnostic tests or getting the follow-up. You can spot where the problem is about, whether it's a problem of not reaching people, or that there's a problem of engaging. There's this term that we see a lot in the UK landscape, and I think elsewhere as well, of difficult to reach, which it gets the hairs up on my spine. Really, it invariably is not enough effort or misguided effort, rather than the people themselves are difficult to reach. All groups can be reached if we think properly about the solution.
Thank you. Can I turn to Professor Pinto? Presenter, you've had much experience of working at the supranational level, at the global level. Do you see what solutions do you see in terms of countries working together at different levels, perhaps in addressing some of the data or in representing the case for change?
Yeah, absolutely. That's actually key, is the capacity to work together and to be able to share some experiences. And this is why global structures such as the World Heart Federation or the Global Heart Hub or many others that represent either the scientific or medical component, but very importantly, the patient groups. And we had a few examples here. It's fundamental that we share the experiences, we share the different models that may apply to certain areas. It's also important that we work very closely with local members, with local representatives, because the knowledge of the local settings and the knowledge of what are the conditions at a local level, they are essential to provide the needed information to then develop the better tools that can be more easily or more properly adapted to the different needs. And that's something that, for instance, our roadmaps look very much at. It's actually working with our local members, organizing roundtables, workshops, and then developing calls to action that can be applied at the local level. And I would say that there is a fundamental need to work closer to decision makers to make sure that the implementation of these strategies can have an effect at the more wide level. Of course, as a physician, I can talk to my patient, but that will affect only the population of patients that will see me. If we want to be more effective, we have really to be much more close to, first of all, to patient groups, and I will reinforce this. It's fundamental, the concept today even of co-creation and working together to find better solutions, and then to reach out to the decision makers so strategies can be implemented in a much wider way, meaning a much more efficient way. So those will be my general comments.
Thank you. Dr. Conrad, you have quite an unrivaled view over data and inequalities in heart failure, as you were explaining. What if would be your ask of future research programs? Where do you think we need to go further in understanding those inequalities and some of their origins?
Thank you for this question. I'm sorry that the video doesn't seem to be working. So where would I like to go in terms of research? Oh, that's where, in terms of research on inequalities. Well, I think the first thing is we have this data from the UK, these large-scale national data sets across healthcare settings that are very special, but only a handful of countries have these kind of data. And very often where it is available, socioeconomic status and ethnicity is rarely recorded. So my first wish would be for other countries to collect and make accessible these kind of data, obviously in an anonymous form. But I think that the first step, if we want to address inequality, is that we need to uncover and measure them. I think many countries might be somewhat blind in the fact that these inequalities are very present. Certainly in the UK, we will not expect to find that many inequality in a country where healthcare is free, as said. So if it does happen in this setting, it happens probably everywhere. So yes, I'm a huge advocate for more data. I know it remains somewhat unimaginable in many countries, but hopefully this will change in the future. There is another aspect where I think we still need to do quite a bit of work, as obviously uncovering and measuring these inequalities is the first step, but why do these inequalities happen? I think ISTE has given us a very good overview on this. I think the data can also help us answer this question and put this forward to policymakers. We do know quite a bit about it. We do know that cardiovascular disease risk factors like obesity, smoking, air pollution are much more prevalent in socioeconomically deprived groups. We do know that medication, especially medication adherence, is not the same in socioeconomically deprived group. But how we can improve access and trust from these marginalized group with the healthcare system, we have part of the answer. Part of it is implementation, but I think from what we have seen during the COVID-19 pandemic and the vaccines discussion, it is not an answer that is that simple. I don't think we have all the answers yet. So I would like us to have more research on that, perhaps in a mix of social and clinical sciences, on what we can do about this.
Thank you, Dr. Conrad. May I offer a question here to the whole panel? At the Heart Failure Policy Network, we've been calling for improved heart failure registries and national audits for several years, based on their importance, as mentioned by stakeholders, in their role in literature and driving change, but also the uncomfortable reality that, just as you were mentioning, very few countries actually are able to run standing audits, and even those that do often have gaps in them. So it is a conclusion from today that not only do we need these registries, but we also have to really engineer these registries to be able to uncover these inequalities. Is that a statement that you'd agree with, and how might we go about doing that? Anyone like to take that one?
Oh,
yes.
No, go ahead, Fausto.
go ahead, Amy. No, I was just going to say that I would say that's critical. Data is knowledge, and the data is power too, and that's why it's so important to have these data collections organized. As you know, scientific societies, some of them, they have organized some registries and some data collection, and there are some powerful registries. The problem many times is that in many instances, this just reflects part of the reality, because they are most of the places in high income settings or in some specific areas. Many times they reflect just what was the question or the need at the specific time for that specific society. I think we're still missing, at least in a more global perspective, data that can be more comprehensive and that can not only provide the usual data that you get in registries in terms of prevalence of disease A, B, or C, or condition A, B, or C, but also in terms of, for instance, what was discussed here, access to medication, access to healthcare, in terms of providing information on workforce. It's a big issue now, the whole issue about the conditions of the workforces and the health professionals at the global level, of course, with some differences among different countries and sometimes even within the same country, but that's an important issue. And those are the type of needs that probably at the level of different organizations could set some sort of common ground that then could provide the capacity to develop, because it's not easy to organize registries, it's expensive. Therefore, it must be done in a way that could be useful and could be helpful to work, on one hand, to organize, and on the other hand, to provide the data that then will be needed to develop proper strategies. So I would say that, first of all, the need is obvious. And the question here is how we can materialize that in a way that can be useful for the different needs and for the different settings. As I mentioned, we are trying to do a little bit that at the World Health Federation with the observatory, which is collating data from different sources. It's not going to be the ultimate data collator or the data setting, although we believe that working with our different members, again, from scientific societies to foundations to even patient groups, that might be a repository of data that could be useful in the future for groups like this to have that sort of capacity to retrieve the data that can be needed to make some cases and to organize some narratives that can be useful at different levels. So definitely, yes, we just need to find the best ways to organize it so it can be efficient and it can be useful, and not only have a set of data that can just sit there.
Thank you, Professor Pinto. Reflecting on the, I guess, the sort of political reality, Aiste, can I turn back to you here, that ultimately to secure these investments, we will be explaining a case for change to elected officials. What are your views on explaining inequalities as a way to connect with, for example, elected officials or politicians who may not know a lot about heart failure or even cardiovascular disease, but they will perhaps emotionally connect with arguments, with real life stories and with narratives of fairness. I wonder if you have any thoughts on, what would our colleagues listening to the summit today from advocacy groups, might they want to, I'm sure they want to consider this angle. Do you have any thoughts on speaking through this, giving messages of equality to politicians in your experience?
Oh,
Yes.
absolutely. Oh, sorry. I thought.
No, okay, please.
No, go ahead. I spoke too much.
No, just answering your question, Ed, that's a great question. And I think, I was in a position here in Lithuania with Lithuania's Heart Failure Association, where we actually have a seat at the table with decision makers. And I would definitely highlight one thing that it's one of the most important things is the awareness. So we know the statistics, like in every country, everybody knows the statistics of heart failure. But I think the most important is that the politicians, decision makers, they do understand the burden of heart failure. So that's not only from the patient stories, that's not only from the patient organizations, that comes from the clinical society, from the payers, and etc. So all I say, it's all about collaboration. It's a two-way street. So the connection and has to come from both sides, not only from decision makers, but as well from the patient organizations. In the rare cases, decision makers do the introduction, send the invitations to different events. And I think that's in the most cases that patient organization has kind of the upper hand to go and start that collaboration, start that conversation, go in and participate, showcase what they did, present, what they are doing, the current works on a national level, and take that to next level by collaborating and working together.
Thank you so much. We are just coming to close to the end of it, but we've got just a little time, one more question. Professor Banerjee, I wonder if you also have a reflection on that partnership between academics, clinicians, scientists, people with lived experience in heart failure, and also the groups that we're talking about. Do we have that alliance, do you feel, to make that case for change at the systemic level? Do we need to think again about our voice as a heart failure community?
We absolutely need that partnership, and we're not necessarily there. I think we historically and culturally in our different jurisdictions and countries have made this harder than it is. If we keep patient care at the center and make data gathering part of normal process, it's scary to people or to policymakers or clinicians to build an all singing, all dancing registry from scratch. But if we badge this as routine care, where it will improve care if we know what's happening, then that's a different sell altogether. And I think we've been for too long making this sound like something extra parallel to improving patient care, when actually it's part and parcel of it. And of course, policymakers need to be part of that conversation.
Thank you. And Dr. Conrad, any last thoughts from you, reflecting on our discussion today?
Thank you very much for the very interesting discussions today. I think it has highlighted many very important aspects of inequalities, ethnic minorities, but also socioeconomic disparities. Unfortunately, we didn't have Martha to speak about women and inequalities. I think that is also a very important aspect that we need to keep in mind. And also, there are many studies out there, including ours, that show very significant disparities among men and women. So hopefully we can get that conversation going also in that direction.
Thank you very much. I know we've run slightly over time, so a huge thanks to everyone who's taken part, in particular our fantastic speakers today. I'll just briefly summarize by saying, for me, the key messages from our session today were that, as you know, we believe that plans, strategic vision from governments are essential to the future of heart failure care for making a difference on the ground. But if we don't plan to address inequalities in heart failure, it seems clear that any such plan or vision will essentially have already failed. We have a way to go quite clearly in this field, as is exposed by the data that we see and also the data that we don't have. So we do need to understand better how some of these manifest, but equally we've got a mandate for action already to justify adaptation, specialization, and I think local initiative, as we say, to get patient-centered care, and that determination and vision that we've seen from some of our case study speakers. It is possible. It seems complex, but there are plenty of other people who we can follow. We'll have to embrace a complexity of factors, and we'll have to think about the trajectory of heart failure all the way from primordial prevention to tertiary prevention, but it can be done. We can make sense of it. There's a balance here between efficiencies of scale working across countries and regions in the way that we collect data and in the programs that we see, whilst also tailoring things locally, as we said, with initiative. But we've seen practical measures, and I think this is an agenda we'd be thrilled to take forward, reflecting as well possibly on some of the roles that we could see within Europe in coordinating some of these efforts and in reducing barriers to entry. So on that note, as I said, a huge thank you to everybody. I hope that all you listening and watching have found it useful today. All the recordings will be available online very soon. And do please join us at our final session of the 2022 Heart Failure Summit, which will be next week at the same time. We'll be looking at some person-centered care models and what we understand about patient quality of life. So a huge thanks, and there we will close the day. I hope to see some of your comments and thoughts on social media, on Twitter or LinkedIn. Many thanks.